as if by magic. My other plea is if you could mute yourselves if you're not talking, please, and then we don't get any feedback or background noise. And my last request for you all to give you something to do this morning is if you've got any questions, any comments, anything, please use the chat and I'll try and keep an eye on that as well. There will be a usual question and answer session at the end, so please keep me busy. So I'm going to move, sorry, I've got multiple screens, so I am still looking at you even if I've moved you to the other screen. I will start to share. Super, you should all be able to see that. So good morning. For those that haven't met me, I'm Claire Holmes. I'm the Operations Manager for Cancer. I think in the audience today, we have also got some other of the senior team. So I've seen Lisa Putt appear this morning, who's our lead cancer nurse. And I've seen Alex Colhoun, who's our clinical director, appear as well, and they are maybe waving at you now. And I say Kevin has taken a day's annual leave today, so has left me to it. So we will make a start. So on the list for this morning, I thought it would be a really good opportunity to update you all on what we've achieved in the last financial year, since we've only got, what, 4 days left now of this financial year. We'll then go on and talk about what our plans are for next financial year, so starting on Friday, and that's both from a national perspective and then what we also plan to do within the Directorate. We've got a really exciting talk and update around sickle cell crisis and some new treatments available for patients. And then we're going to have a little bit of an update on Attend Anywhere as well, and maybe give you some helpful hints and tips on how we can use Attend Anywhere within the Directorate. And then my favourite question and answer session at the end, so I say please keep me busy. So hopefully you've seen this little table, as there's 2 pages of tables before. This was all the things that we said we were going to do in the last year. And in fact, if I'm honest, some of these were what we said we were going to do back in 2020-21 as well. And obviously due to the dreaded COVID word, some things have been delayed, but I think it's a really good opportunity just to keep you all updated on where we are with these things. Lots of them, say, are going green, or we're very, very near completion stage on some of them. Some of the red items on there we've either chosen not to do this year, or they are part of national commissioning changes, which means we can't do them. So a really good example of that is the Schwartzman-Diamond syndrome service, which we are waiting for national commissioning to come through and let us know that we can start that service. So sort of outside our control, really. But there are some really fantastic bits of work that we've started to do. We've managed to successfully get another year's funding for Maggie's psychological support for our cancer patients, which is fantastic, and we hope to have a permanent solution for psychological support for cancer patients in the next year. We've successfully become an approved, I'll say TTP centre, because please don't make me pronounce what it actually stands for, which is a medical haematology achievement that we've had, which has been brilliant. And I think the other key bit for me is we're really starting to use some of the EPIC data better. You all input so much stuff into EPIC. It's a brilliant tool. We need to now start using it and get some data out of it and make things a lot easier for us. So some fantastic bits of work there. Our next list that we had, again, there's been some areas where we've really struggled on, and I think for me, a focus for the next year has really got to be on our workforce, where we've got new roles. How can we put some training in place, supervision, support for staff? What else can we do to support our workforce? Without you all, we wouldn't be able to deliver the treatments that we do to our patients. So I think that's got to be a key area of focus for us. We managed, which was fantastic, to get some of our posts that we've had approved on a sort of fixed term basis. So a lot of our cancer navigators, some of our specialist nurse posts, we got approval for 12 months funding, but obviously we really wanted those in place permanently, and we've managed to achieve that now, which is fantastic. And obviously the Cancer Research Hospital is still going on, and Carrie and Elaine aren't with us today to give an update, but at the next briefing we will give you updates, and there's obviously the staff forum as well for that. There's a couple on this page that we've marked as amber, so the cell therapy laboratory. We managed to get a business case approved for some additional staffing for cell therapies, and that team in particular has really struggled over the last year with increasing workload, so more patients that need their support, and not increasing staff numbers. So it's fantastic to see some extra staff for them, and they're actively recruiting now. So hopefully in a few months' time things will appear a lot better for them. So I think all in all, with COVID and with staff absences and everything that we've had going on in the last year, I'm really pleased that we've managed to achieve a lot of things. There's absolutely still work to do. I think one of the bits of feedback we had on these objectives was that there was an awful lot here for us to achieve, and were we being too ambitious? And those of you that know me know I'm quite impatient and I like having lots of things to do, but we do need to think about what's realistic, I think, for us to achieve, and maybe some of the timescales. And again, are we too impatient and we want everything done quickly? Some things do take a long time to achieve, but I think it's really important that we recognise that and still try and push on with some things. So I will keep updating these lists, and as we'll go on to talk about our next year objectives, we can then maybe think about what else we need to add to our list. So some of you may know of these things already. NHS England has produced a national plan. So it's a national plan for 2022-23, and it covers everything across the whole NHS. What do they want us to do in the next year? Obviously, a lot of that is around recovery post-COVID, and what are we going to do to reduce our waiting list? You'll have all heard in the news about how many millions of patients are waiting for treatment. What I've done on this slide, that the large document is many pages long. What I've done here is tried to pull out the key items that are relevant for us within the Cancer Directorate. Some of them will be more relevant to your teams than others, and I say there is a load of other stuff in the guidance. These are really the key things that we are going to be asked to provide evidence or work towards. What I'm really keen that we do is we do not rule our lives by this guidance. So this should be an output of really good quality care that we provide. All of these won't be relevant, I say, to all teams. So a really good example that often gets quoted at me is some of our haematology patients who have got long-term conditions. They have to come in for regular follow-ups. We cannot reduce those in any way because for their clinical condition, they have to be seen at certain intervals. Therefore, they might not be able to achieve a 25% reduction in follow-ups, but it might be that another specialty could do that. So as long as a whole directorate, we're thinking about where this would work best for our patients. This has got to be about what is best for our patients and providing good quality care. We all know that we can achieve a target, but if the quality is not there, why are we really doing it? So I'm really keen that we do this in a very sensible way. We've already obviously started working on some of these. So to deliver 10% more elective activity. So we've got to be doing more planned procedures. So that's our day unit chemotherapies, our surgeries, our bone marrow transplants, anything that we do that's planned. And actually a fantastic success over the last year is we've actually delivered as much bone marrow transplants as we had done pre-COVID, but with 6 less inpatient beds, which is fantastic. I don't know how we've done it. It's brilliant. So everything like that we do just allows us to treat more patients and ultimately to reduce those waiting lists. We have got in some of our services, so particularly in neurology and medical haematology that offer routine services, so non-cancer, we have got lots of patients waiting a long time for treatment. I think urology have just managed to reduce patients waiting over 2 years for treatment down. So we've removed all of those patients now, and we're now working on patients that have waited over 18 months. It's a really long time if you were that patient waiting. So we've really got to try and reduce those waiting lists down. And we do that by being more efficient with what we do, trying to make best use of our theatre list, best use of our clinics, and not seeing patients that don't need to be seen. And I think that's the real key here. So this is about what's best for the patient. Would you want to drive to Addenbrooke's, pay a fortune to park, sit in a clinic that's overrunning for a quick 5-minute consultation with a doctor that you don't really need? So that's what we've got to try and focus on in the next year. The bottom one on here, for those of you that are involved in flow on a daily basis, we know that the conversations around there's too many patients in A&E, there's ambulances waiting to offload. And we've got to do our bit in cancer. We have a fantastic cancer assessment unit that looks after a lot of our emergency patients, but we do have patients who come through ED who can spend a long time on a trolley in ED, and that's not where we want patients to be. So we've got to make sure that we can discharge patients from the ward earlier in the day. They can obviously then get home to their families, which is best for them as well, and then we can get our emergency and our elective patients in. So that's a really key one for us to focus on in the next year. Within the national guidance then, there are cancer-specific actions, and these are obviously cancer across all cancers, so they're not necessarily relevant to the Cancer Directorate, some of them. These will be things that I'll be working on with teams, say, across in other divisions. The green ones on here, if it doesn't come across very well, are relevant for us in the Cancer Directorate. So there is obviously generic things on here about reducing patients who have waited a long time, making sure that we are increasing our number of treatments to catch up on patients that may have missed out over the COVID period. There's then some specific stuff. So for prostate cancer, doing an MRI prior to biopsy, which is something we've done here for years, which is fantastic to see it in this guidance. And then really a focus on getting patients diagnosed with cancer quicker and at an earlier stage. So if we catch cancer at stage 1 or stage 2, patients often have better outcomes, better recovery. And so there's a lot of focus on that in the guidance. And obviously to do that, we need our GP colleagues, primary care, health awareness, that sort of thing, to be in place. There's a second page of this, sorry. So, and again, this has got some really specific stuff, particularly for our cancer support team. So around personalised care, so making sure patients' follow-up is personalised to them. We've got supportive navigators. We've got our risk stratified follow-up in place that we've always had here. And again, a lot of this we've already started in previous years, which is fantastic. We can continue that work. The one in here that's fairly new to us is testing for Lynch syndrome. So this will impact on colorectal and the gynae oncology team. And again, we've started some work on that, but it's fantastic to see it all in here. The one key one for me here is this one around increased recruitment and retention of CNS's support workers, navigators, anybody that's got anything to do with cancer, basically. And as I said earlier, I think it's really important now that we look at what we can do to support recruitment, to make sure that those of you who are in a post remain happy and supported in your posts, and what can we do to further train and support you in your roles. So they're all the national requirements. CUH have then got our CUH priorities. These haven't changed from a couple of years ago. They're, let's say, still fairly standard. What we've done in Division B is we've pulled things that we want to do in the Cancer Directorate into the Division B priorities. So again, sorry, these are a bit small on your screen. Some of these will be relevant to us, and again, some won't be. As you know, Division B is quite an eclectic group of services. So we've got things in here specific for pathology and imaging. But this is where we feed into, and these are the things we've really got to focus on to do best for our patients and our staff. I think what would be really helpful is if within your specialties, we sort of now take a bit of time and go away and look at what do we want to achieve on a local level. So, you know, we've talked about things, you know, how do we deliver chemotherapy in a different way? How do we look at implementing patient-initiated follow-up and reducing our follow-ups? And Paula's going to talk to us about Attend Anywhere later. What can we do locally? What do you want to do to support achieving these? And I'd really, really like you to think about the quality of that, and it might just be going back to basics on some things. These don't have to be huge, great, big, you know, changing ideas. Just really simple things. You know, how do we make sure we've got a patient's name, address, telephone number correct on the system when they come and check in for an appointment? How do we make sure that people aren't missed having a follow-up appointment? All those sorts of things. How do we make sure when they're admitted to a ward they have a good experience? Let's really go and look at the quality of some of the stuff that we do. So I think we've had a fantastic year, but hopefully now we can look forward and think about the exciting things that are to come in the next year. The one bit that I promised I would do today, so for those of you that can remember back a long, long time, we had a cancer strategy that we spent a lot of time developing 4 years ago now, and it has come to an end in 2022, so we needed to refresh it, which we have done. We have done a quicker refresh of rather than spending lots of time in a room for those of you that were there 4 years ago. But hopefully it's a very, very similar ethos. We've involved patients in it and various different professional staff groups. It is available on our Connect page, and I figured out this morning that my link to it doesn't work, so I will correct that before I circulate these slides. But if you put into Connect Cancer Strategy, it should come up. Have a read, share it. Again, it's Cancer Trust, so for the whole trust, it's not just Cancer Directorate, but it just covers why we're here, why we do what we want, why we do what we do, and what we want to achieve for the future. So please have a read. I'm really hopeful that all these sort of objectives and things that we want to focus on will help you when you're thinking about your appraisal, which will no doubt come round rather rapidly this year. and really help you understand how you make a difference in the Directorate, and how everything that you do will contribute to us achieving these objectives, and ultimately for me making our patient experience far better. So thank you very much. I've got the dry, boring topic this morning. I'm going to hopefully hand on to Martin, if he's there, to talk about sickle cell.
Hello.
Morning, Martin.
Hello.
If you tell me when to do next, I will be your...
Yeah, sure. I've got some fancy effects in there, so could you switch it to slideshow?
Oh, well, I have adapted your slides and put them into my template, so I might have lost your formatting.
Okay.
Sorry, bad
Wanna
me.
try? Do you want to try? So at the bottom right. Yeah.
My Zoom goes funny if I put it into viewer.
Okay.
So
Fine. Is Nika on the call?
I think I saw her name somewhere.
Just so I know if she's here. Otherwise, there'll be a moment of silence later.
I think so.
Yeah.
Can you hear us? Ooh.
Hello.
Yes. Hello. We've got you.
Apologies.
Hi, Nika. So I'll do the slides and I'll pass over to you. Is that okay?
Yeah, of course.
Yeah. Okay.
Do you want to introduce yourself as well, Martin? I'm sorry, I didn't.
So yes,
do that.
I'm Martin Best, a hematology consultant. I do non-malignant hematology, and we've had early experience with the use of a new drug called crizanlizumab. Can you go back one slide for me? That'd be okay. So this drug has now been approved by NICE since November 2021, and as of February, we're supposed to be able to offer it as a drug for NHS patients. And this is just a bit of background about what it is, and Nika will give us the patient perspective about the availability of this new drug. So if we go to the next slide, please. So this is a sickle cell. So sickle cells, as you know, red blood cells are supposed to be biconcave squishy discs. And in sickle cell disease, a single point mutation in the beta chain of hemoglobin means that when the pH or the oxygen tension within a red cell is not right, the red cell can be deformed by hemoglobin crystallizing. So these little balls here arranged in a chain are supposed to represent the long needle-like crystals that form. So for this process to take place, the conditions for the red cells have to be pretty adverse. So they have to be in an acidy environment and the oxygen tension is low. And once this happens with delay. So the reason for the sickle cell shape is not only the crystals that are sort of longitudinal, long spiky needles, but also that this tends to happen in the very slow flowing areas of the capillary bed. But because it happens with slight delay, often the red cell leaves the capillary bed where the deformation has taken place, and then get stuck in other areas of the body. So particularly in the vascular bed of the bone marrow, where it can lead to very painful blood vessel occlusion. The complex process that is triggered by this simple structural change in the hemoglobin affects the hydration status of the red cell and the expression of surface markers. So even though this process is very difficult to control because it's down to a genetic change in the structure of the hemoglobin, the process that causes the painful crisis later down the line when the red cells become deformed and adheres to another area of the body has many targets that one can interfere with. So if you could show the next slide. So this is a picture just to give you an impression how complicated this is. So you have up there a blood vessel. On the left, you see the red cell starting to deform. Hemoglobin is released because some of these red cells burst. The neutrophils get wind of the situation and start releasing their enzymes and so-called nets, looking for bacteria to catch, because they think if there's so much trouble where red cells are breaking down, there must be an infection that they can take part in. And ultimately, these red cells deform, change shape, and then adhere in the area where blood flow can easily be occluded. And in these areas where the red cells get stuck, you have a meshwork of platelets, white cells, red cells, and the blood vessel bed interacting with one another. And these painful crises are essentially caused by these massive pileups within the blood vessel. So if you go to the next slide. the best example is like a big crash on a motorway. So these jackknifed lorries are essentially the red cells, and you get all these bystander traffic involved in the area, and the white cells are coming in, like the police here in this picture, trying to figure out what's going on and trying to fix it. And by taking part in this, they're actually making everything worse. So if we go to the next slide. The structural mutation of the hemoglobin that causes the problem, so the single amino acid exchange, is a very hard target to interact with. But the drug companies and scientists have become aware that you can interfere with the other tissues that are taking part. And crizanlizumab, interestingly, doesn't actually interfere with your red blood cell, but it interferes with the adhesion of the platelets and white cells to the abnormal vascular bed. And it's an interacting pathway. You've got these 4 circles. You've got the top circle, which is the root cause of sickle cell disease, the formation of crystals. But you have the vasoocclusion, where the blood flow is abnormal, where there is abnormal adhesion between red cells, white cells, endothelium, and platelets. Then you have the resultant sterile inflammation. And ultimately, if this happens often, there are many areas in the body of a patient with sickle cell disease that are very prone to pain, and where even minor sickle crisis can cause trouble. So trying to interfere with the sticking of the other blood cells to the abnormal vascular bed and to one another is a very attractive target. And this is where crizanlizumab comes in. So by interfering here on the right in the circle so at 3 o'clock, it means that you can interfere with the process and relieve and reduce the chance of crisis. So if we go to the next slide. So sickle cell disease patients, so it's the most common monogenic disease there is in the UK. There's believed to be 15,000 in the UK. You can see on this heat map from the National Registry where most of the patients live. So over half of the patients with sickle cell disease live south of the Thames in this very center here in London. But you can see that the historic industrial beds of the UK where lots of jobs were in the 50s and 60s are also areas where many people with sickle cell disease live. But gradually other areas of the UK are becoming more and more aware of just how many people with sickle cell disease live there. So we have more sickle cell disease patients than cystic fibrosis patients. And so from my own experience in 2009 when I was appointed, we didn't have a single patient who had regular red cell exchanges. Now we have 11. And we were aware of about 20 regular adult patients and about 20 admissions per year. And we've now in the last year, we've done 59 annual reviews, so we've roughly tripled our number of regular patients that come for us to follow up. We still have about 20 admissions per year, and we know there's about 80 children that are coming through. So it's rapidly increasing in importance, and it is a very important disease to have treatments for. At the moment, up until the NICE approval, there was only a single treatment, which was hydroxycarbamide. It's a tablet. It takes 3 to 4 months before it has an effect. And it's a very unpopular treatment for patients to take because of the very gradual effect. And success is essentially when nothing happens. So it's a very frustrating tablet because it takes so long before you have the benefit, and you only realize the benefit in retrospection. And you're sort of on your own with this tablet. We have many patients who are started on it and then they stop it again. The main evidence for this treatment is in hemoglobin SS sickle cell disease, but about 25% of patients in the UK have hemoglobin SC sickle cell disease. And we extend this treatment also to patients with hemoglobin SC disease, but there's not much evidence that they derive the same benefit. And because there's only one treatment, there's only the one size fits all treatment, sometimes, particularly in SC disease, it causes a rise in the hemoglobin. And it's then tricky if the patient continues to experience crisis despite being on SC disease, whether you then go ahead and remove pints of blood again from the same patient. So it's all very 1960s, 1970s, up until the arrival of this new treatment. So if we go to the next slide. We have recently changed the way sickle cell disease care is provided in the UK. It's now provided in these sort of columns. So here on the left, I've written our arrangement at the moment. So we have Our HCC is UCH and the Whittington. Our SHT was the North Middlesex, but at the moment there is no capacity in the North Middlesex to fill this role. And we are technically a local hemoglobinopathy team. There was an animation, which of course we now haven't got. Essentially, we are planning to get upgraded to the specialist hemoglobinopathy team status, because we literally have all the facilities that one would want. It's something we're working on to try and provide better care. But to become an HCC, I think that is in a very distant future. But we're hoping that we upgrade our status to an SHT. So if you go to the next slide. So crizanlizumab, the approval by NICE is based on the SUSTAIN trial. So the SUSTAIN trial was a phase 2 study that was completed in 2017 and published, I think it was published also in 2017 in the New England Journal. Yeah, there it is, down there. And there was a randomized controlled trial of 2 doses of crizanlizumab versus placebo in about 160 patients. The treatment was given over a year. Crizanlizumab is an infusion that has to be given once a month, and they then looked at the likelihood of crisis. Importantly, they allowed all forms of sickle cell disease into the trial. The only precondition was that patients needed to have had 2 major crises within the last 12 months before enrolling, and no more than 10. So if we go to the next slide. Whoops, so these are the results. So compared to placebo, essentially, you saw that patients who received the highest dose of crizanlizumab had half the chance or half the rate of vaso-occlusive crisis over the 12-month period. So very convincing. If we go to the next slide, the difference emerged from 2 weeks after treatment. So you can see the red line is the cumulative event rate in the placebo group. So you can see that goes up quite quickly. Of course, some people are lucky and don't have a crisis in that year. But if you wait long enough, someone who had 2 crises in last year is quite likely to have at least another crisis this year if you wait long enough. And that's your survival plot here, essentially, in terms of being crisis-free in these 12 months. And if you look at the green line, this is the group that received the highest dose of crizanlizumab. You can see that, yes, patients there also experience crisis, but significantly less so. And you can see that from about 2 weeks after the first dose, the green line and the red line diverge from one another, and they do not meet again throughout the entire period, which is important. So this is very convincing that crizanlizumab halves the chance of you having a crisis, and it does so within 2 weeks, which is an advantage over hydroxycarbamide. And the other advantage for us is that we know we have given the drug because we're giving it as an infusion. So if a patient doesn't come for infusions anymore, it's immediately apparent. And it allows us to troubleshoot and find out why patients are no longer coming. With hydroxycarbamide, the curves from the original data in the 1990s looked similar in effect, but I have a massive problem with patients not liking hydroxycarbamide, then feeling a bit embarrassed about it, not coming back to see us, and continuing to experience crisis at home after they've stopped it themselves and not told us. And I think this is a huge breakthrough that we are able to provide planned care for patients with a very disabling disease that is very difficult to provide good care for. And the ability of us to sort of intervene and say, here we have a treatment for you that's going to work within 2 weeks of us starting it. And we immediately see if the patient is lapsing or giving up on it. And the other advantage is many patients with sickle cell disease describe the discomfort of being in a cancer ward, receiving care next to lots of cancer patients who often have a very good relationship with the cancer nurses. And of course, because they come at an unpredictable point in time, often don't have the same relationship with the local nursing staff. And I think it'd be a huge advantage if we start offering planned care, and patients will have a chance to sort of educate us as well about sickle cell disease. And it will be a far more familiar disease for all of us if we have patients who receive planned care. So if we go to the next slide. So here's another bit. Essentially, about 35% were completely crisis-free in the first year, which is good news compared to placebo, where there's only about 17%. So if you go to the next slide, and it worked in all situations. So you can give it on top of hydroxycarbamide, that's the column on the left. You can give it to people who had 2 to 4 crises or 5 to 10. And very nice, it's not always the case in medicine that the more crisis people had, the stronger their effect. So they went from 5.3 crisis in the most severely affected group to 1.9. So relatively, even if you're very badly affected from crisis, crizanlizumab seems to have a distinct advantage even in that group. And also the genotype didn't matter. And ironically, you could say that there's now better data for the use of crizanlizumab in hemoglobin SC disease than there is for hydroxycarbamide. So if we go to the next slide. Yeah, these are the side effects. They're very manageable. So the main problem that the Americans who've had access to this since 2019 have discovered is that about 1 in 1,000 patients can have a crisis trigger during the infusion, and that can be so severe that it leads to admission. And it can also be so severe that it prevents further doses from being given. I've never seen this as a reaction, but it's something to be aware of. The other side effects are very similar to other monoclonal antibodies. And interestingly, there's currently no safety bloods. It takes about half an hour to infuse, and there's some safety observations to do to conclude at the end. So very, very straightforward to give. So next slide, please. So the Department of Health predicts that of our 15,000 UK patients, about 4,000 patients in the UK will be on this treatment by 2025. So for our numbers, assuming a lot of the teens come through as well, we would estimate that we could be treating between 25 and 40 patients long term. So this is open-ended, so it will have significant impact on our capacity, because these are patients currently who are not receiving day unit treatment from us, other than maybe for the most severe ones who are on regular red cell transfusions or exchange transfusions. And the good news for us, this may allow us to reduce the chance of hospital admissions in patients. So it could mean that we see 10 less unplanned 5-day inpatient episodes as a result. And of course, we'll have much happier and healthier patients who feel better protected and have a better relationship with us, particularly those who need us most. So if we maybe go over to Nika, and then we do the final slide in the end. So Nika is one of our patients who is in the successor trial. I showed you the data from the SUSTAIN trial, and they were criticized because they only had 12 months follow-up, and a third of the patients who were treated were on this 2.5 milligram per kilo dose, which was not always significant. So they've designed a subsequent trial that was done across the world. So the main trial was Jamaica, America, and Brazil. And this is called the STAN trial. So in the UK, we had, I think, 9 places, and we turned out to be the main recruiter in the UK. So Addenbrooke's, despite having only 1% of the caseload in England, had 4 cases in this trial. It's still a blinded trial. So Nika doesn't actually know if she's on the real drug or on the placebo. We'll find out in August, which we're very much looking forward to. But Nika is basically a bit of a celebrity because she was the first patient, or the second patient in the UK to enter the trial, and is probably one of the longest patients on treatment with, we presume, the treatment drug. But of course, it could also be the placebo. So maybe Nika, if you could give us your perspective. Nika is also a radiographer who works with us, so many of you will have seen her.
I'll stop sharing and then we can see you, Nika.
Hi everybody, I'm Nika Smith. I'm currently on secondment in the education and retention team as the AHP workforce lead. But as Marty said, I'm a diagnostic radiographer by background and also an ex-teacher, so I've done a lot in my life. But one of the reasons I changed were the complications. So I suffer from hemoglobin SC. So I don't have the SS, which most of you would be more familiar with as sickle cell anemia. So I suffer from some very different results from having sickle cell. So I tended to have 2 to 3 crises that required hospitalisation a year. But my main issues were joint concern. So I've had avascular necrosis in my right hip, and I've had decompression surgery. I've had partial discectomy, and I've also acquired fibromyalgia as part of the issues with having long-term chronic pain and my body's response to it. So I have lots of musculoskeletal issues on top of that. So although I've managed to keep working and I work full time, I am registered disabled, so I have a blue badge, which gets me lots of funny looks because I don't look like I should have one, according to people's opinions. But there are days where I can't get out of bed. I've had less of those lately, so I'm on week 100, and I think my last infusion was week 111. So that's how long I've been on the trial for. And since I've been on the trial, I haven't had a single vaso-occlusive crisis, let alone a hospital attendance. So fingers crossed, that means I'm on the drug, but we'll see in August, as Martin said. We tried to get first in the country. We just missed out by a week, I think it was in the end,
Yeah.
Martin. But I'll take being first in CUH. And we've since managed to recruit quite a few more on the trial. It's quite straightforward. I have my infusions in a bit of a longer lunch break, so my team have allowed me to work while I have my infusion, so I attend a few meetings while I'm hooked up and getting my infusion. The infusion itself is about 15 minutes long, but because I'm obviously on the trial, I get observations for an hour and a half afterwards, and some observations before and safety bloods and things. So all in all, I'm probably in the research centre for about 2 hours. And then I come back to my office and finish off my day and keep going. So yeah, it's been amazing. So the type of sickle cell disorder that I have means that I'm not suitable for some of the other treatments, so the hydroxycarbamide, for example, which many of you might know because it was used as a chemotherapy drug. So you can imagine the reaction and the impact it has on patients who suffer from sickle cell disorders, having to use a drug like that as their only way of trying to get relief. And I'm not suitable for that. And actually, there is no official treatment for SC disease at present, apart from the crizanlizumab, which has now been approved by NICE. So at first, NICE refused to take the drug on board, and we lobbied and we explained kind of why it is such a great opportunity for those with sickle cell diseases, because for those who don't qualify for the hydroxycarbamide, this can now be a treatment that would change their lives. I have had improvements in my joint pains, my mobility. I've had, I think, 2 red cell exchanges, but they were precautionary because I was going for surgery. But other than that, I've had none of that. The only thing I've needed is some physiotherapy, so I get hydrotherapy, and so far so good. So fingers crossed, that means I'm on the drug, and we'll find out in August. So if anyone has any questions, I think we've got a couple of minutes left. Have we got, Claire?
Thank you. Yes, that's really, really kind of you to share your story. That's fantastic. Do you want me to share your last slide, Martin?
Yes, we'll
Then
go
I'll
to the last
take
slide.
questions. Yeah. Find you again. There we are.
Okay. Yeah, so I think we've done really well. So we only have 1% of the English sickle patients, but we're the lead recruiter. We've actually stolen the chief investigator hat probably from May this year because the professor is retiring who was doing it before, and they've come to us because we've outperformed the guys in St. Thomas. I always feel like we're in like a little pirate schooner, you know, going around the big Spanish galleons in London. So I take great pleasure in getting one ahead of them. We have the only EPIC registry in Europe, the last time I checked. So there's about 22 in the world, and we're the only ones so far who have used it, which is better than the national registry because we can give much better care to our patients because we can see straight away what's missing. Nika has joined some national groups, so that's again a huge achievement that we've managed to raise the voice for people who are being treated in Addenbrooke's, and there was in the parliamentary inquiry we may have been following recently, and some of our patients have also been on Channel 4 this year. So again, because we have such a small number of patients, we're mighty pleased that we've achieved this. And on the right is my kids' impression of what I've been up to last year. It's what I got for Father's Day. So this is me me, the dinosaur. That Ricard said 1 year closer to extinction last year, and that's what I'm doing in my home office. So the book is the sickle cell. The website is the sickle cell website, and there's lots of other books that say sickle cell anemia. Papasaurus and his sickle cells is at the bottom. But anyway, I think we've done really, really well.
That's fantastic, Martin. Thank you very much. And Nika, thank you for sharing your story again. I will say, if anyone's got any questions, can we put them in the chat for conscious of time? But yeah, absolutely huge achievements there. I think you undersell what you've achieved, Martin, so thank you very much. It will be certainly a fantastic treatment to start, and will have a huge impact on, yes, a small number of patients' lives, but a massive impact, so really
long term. I mean, if you hear Nika's story, it is very, very heartening for us, and it wasn't immediate within 2 weeks. It has taken some months, but it has been very, very convincing. So fingers crossed that.
Certainly, the feature on Channel 4 is a good watch. So
yeah, that is very good for people who are not currently on it, and to understand better what's happening. So we're hoping it'll be prescribable from tomorrow on Epic, and we have 6 patients lined up. We just need slots now from the day unit, and hopefully that.
So yeah, we're going to start in the haematology day unit, aren't we? So thank you to the guys in the haematology day unit for making this possible. But yeah, we should be a fantastic achievement, and keep trying to take over the world and push London out. Absolutely.
Yeah, that's right.
Super. Thank you very much. So next, I think we've got Paula. Have we? Are you there, Paula? Yeah. If you shout at me, I will. Oh, we can't hear you.
Can you hear me now?
Yeah, that's better.
Hello,
Super.
everyone.
You tell me to move, and I'll move.
Thank you. So my name is Paula Kabala, and I work for the Cancer Directorate as a project coordinator. I'm going to quickly talk about Attend Anywhere. So next slide, please. So for those of you who don't know what Attend Anywhere is, it is a platform that allows offering video appointments to patients. It also enables patients to have appointment from home, so without the need to travel to Edinburgh's, the hospital. So saving money on petrol, on traveling, and obviously time. It also allows clinicians to provide the same high standard of care to patients, so the same standard of care and appointment as face-to-face appointment. So usually clinicians decide who those would be offered to, depending on patients' individual needs. But also patients can request this. So if there is, for any reason, if there is a telephone appointment or video appointment they would want to change to, if there is any face-to-face or video or telephone appointment, if they want to change to video appointment, they can do that at any time. But also if they don't wish to have the video appointment any longer, they can change it to face-to-face or telephone at any given time. So equipment required. So we basically need a laptop or a computer with a webcam or microphone and speakers in order to undertake the video appointment with patient, reliable connection to the internet, and also a web browser, but that cannot be just any browser. It needs to be Google Chrome, Microsoft Edge, or Apple Safari, and also a quiet private space to undertake the appointment to ensure patient confidentiality. Next slide, please. So this is the Attend Anywhere staff information pack. This has been designed for director staff members to provide essential information about booking patient video appointments, and also to provide short guide on how to use Attend Anywhere. And as we can see, there is some helpful information on Attend Anywhere, such as how to start the appointment, connect with the patient, how to send a message to patient when running late for clinic, how to add other people to the call, such as spouse or carer, or how to add staff members to the call. Anything in terms of transferring patient to another colleague or back to the waiting area. But also there are some useful links, YouTube videos. So for any reason, if anyone needed a refreshment of how to use Attend Anywhere, you can refer to those. We've got a link to Attend Anywhere included in the pack as well, which will take you straight into the login page, and also some information about additional support if required. The last page, I think, of the pack is about making the most of telephone video clinic appointment, which has been put together by CPPG patients and the co-production lead, and it's very useful information for everyone, for staff and patients. And this is going to be available in April for staff members, and the link will be shared via email through Directorate weekly updates. Next slide, please. So Attend Anywhere process for booking. So we've got those included in the pack as well. So we've got different processes for hem-oncology, non-malignant hematology, oncology, breast oncology, gynae, oncology, urology, and radiotherapy. The processes are very similar. The main differences are around teams involved in booking appointments, and obviously the links to waiting areas, but generally all the processes are very similar, and those are included in the staff training pack, and will also be available for Directorate staff members from April. Next slide, please. So this is just to quickly show you what the consultation process is. It is very easy. So the first step would be to go to the Attend Anywhere website. So those of you who have access to Attend Anywhere already would have to just go to the website, and the link obviously is included in the pack and the policy. All you would need to provide is your email address and the password and log into the system, which will take you to the waiting area. As you can see, I've included here the CUH hematology oncology waiting area as an example. So in order to admit the patient, we've got two patients here. One is waiting for 2 minutes, another one has just joined. In order to admit patient to the call, you would have to click on the little arrow right next to their name, and then it will give you option of join call. Click on that join call, and that will take you, this basically opens the call screen up, and you can start the call with patient. And on the right side, you've got the screen with patient in there. You've got some options below, which is the chat, microphone, camera, blur, and share screen and invite options. So obviously a chat is, you can directly chat to patient during appointment. So you can exchange messages, microphone and camera in order to switch it off and on for any reason. Blur is to get rid of the background if there is anything inappropriate in the background. Share screen option obviously is to share anything you would want to show patients, so such as CT scan results or something like that. An invite option gives you three different options to invite guests to your call. So if for any reason patient would want to invite a relative to their call whilst being at the appointment, you can just click on that option and it will give you 3 different options of sending the link by email or by text message, or just copying and pasting some instructions to your email. So that's what it would give you. And the clinician, in order to actually admit an additional person into the call, would have to stay on the call with patient, go back to the waiting area, as you can see below, and then select the person from the waiting area in the same way, clicking on the little arrow right next to their name. But in this instance, it wouldn't give you an option to join the call because the patient is being seen. It will give you an option to add to current call, and that would bring a box with with the information to make sure that you're happy to admit that person to the room. After the appointment, in order to finish the appointment, you would have to go to the top right hand corner, where you've got two buttons, green and red. One is to refresh if there are any issues, and then the next one is to end the call, which gives you three different options: to return to call, to end the call for yourself, or to end the call for everyone. If you select option to end the call for yourself, that brings everyone in the room back to the waiting area. So if for any reason you would want to bring patient back to the waiting area because they would be waiting to be seen by somebody else, then that's the option to choose. Otherwise, you would have to click on end the call for everyone, which would basically end the call for patients and yourself. Next slide, please. So Attend Anywhere Directorate policy. So it outlines the process of management of video consultation within Cancer Directorate, and it includes useful information such as contact information for access Attend Anywhere, which we've got key contacts within Directorate included in the policy in order for you to get access. In terms of any issues, there are some other email addresses that you could contact directly. We've got the link to staff training pack. So the training pack that I spoke about earlier, the link to that will be included in the Directorate policy. We've got some Attend Anywhere patient leaflets. At the moment, we've got hematology, oncology, TIA, radiotherapy, and urology. I'm working on getting some more, and these are all, the links to those will also be included in the Directorate policy. There are also some direct instructions on how to book a video consultation for patients on Epic. That's for clinicians and admin, and how to change the visit type to telephone in case patient decides not to go ahead with the video appointment. And also some information on how to refer patients to Macmillan Cancer Support Team, which is currently via Epic, but our plan and our hopes are that in the future it will be available through navigators who will be able to support with ad hoc requests. And also we want to include that information in patient video appointment letter, so they could book a member of Macmillan CUH Cancer Support Team to see them in advance. So hopefully that's going to be our future, and obviously we will include all of this in the policy and training staff training pack once available. And the Directorate policy is going to be available from April for all Directorate staff. And this is also going to be shared via email through Directorate weekly updates. Next slide, please. So I included some clinician and patient feedback in here, which in general was very positive. So as we can see, clinicians expressed that it is very easy to log in and to use. They haven't in general experienced any issues with it. It's very useful, especially when talking to patient and sharing the screen with, for example, CT scan results, but also very useful for long-term trial follow-up patients or patients being followed up on chemotherapy, because they can assess, clinicians can assess if patients are well enough to have more treatment. From patient point of view, it also patients also expressed that it was very easy to use without any problems, especially useful due to ability to join from home, because there is no travel involved when they are feeling fatigued, and obviously the option of having family members to join is very, very useful. And overall, the feedback was that Attend Anywhere is better than a phone call. So very, very, very useful feedback. There was one area of improvement. No, just quickly. There was one area of improvement identified from patients and from clinicians. So in case of running late in clinic, patients basically are tied to the computer screen, and sometimes clinicians don't have a way of informing patients of the wait or how long they would have to wait, and that was highlighted from patients as well. But we are actually aware of this issue and we're already addressing it as part of outpatient transformation, and we're just trying to find the best way to improve it. Next slide, please. So that's the key contact details for access. So those are on or access only. So if you have any issues in terms of using Attend Anywhere, you wouldn't contact those people. You would only obviously contact them if you require access, but not if you require access to any additional waiting areas. It's just for people who haven't, previously had Attend Anywhere. And these are the details for any issues and for additional waiting areas. And that's all. Thank you very much.
Thank you, Paula. That's really helpful. I think I would really encourage clinician specialist nurses, even administrators amongst you, to really think about where we can use Attend Anywhere. If we've got patients travelling a long way to come to clinic, would a virtual appointment benefit them? It is a really easy system to use. If you want to do practice test runs with people, we're very happy to offer that. We can arrange that for you, so you can test it before you go live with patients. These appointments should still be booked though in the same way as a normal outpatient appointment. So it's not really acceptable to say to a patient, I'll ring you at some point on Monday, and expect patients to wait around for you. They've got to be booked, organised appointments. You can have multi-professions, so you can have your clinician, your specialist nurse, your navigator there as well. The patient can come back into the waiting room and go into a different virtual room to see the specialist nurse. So it should really be as good a quality as face-to-face. Again, not one size fits all, so use it where it's relevant, but please ask for any help and advice if you need it. I'm very, very conscious of time. I have 3 frequently asked questions. If anyone else has got any questions, please put them in the chat. I will quickly go through the 3 that I've got on my list. COVID lateral flow test was my first one. I know we're all desperately waiting to hear what's going to happen after Friday with free lateral flow tests. There's been no official national guidance, and this is for either patients or staff at the minute. I believe, good old Facebook, I believe that if you go and order your lateral flows on the government website, you are asked a new question now, which is, do you work for the NHS or are you clinically vulnerable? And if you click yes, you should still be able to order lateral flows. I think there's been some supply issues, so I would encourage all of you to make sure you've got some lateral flows at home, and any further national guidance, particularly I'm aware of our day units and radiotherapy who use lateral flows for patients. We will get it to you as soon as we hear anything. Obviously, COVID numbers are really high at the minute in the community and within the hospital. So please, social distance, wear masks, wash hands, all still the same rules. I know it's boring and I know everyone's fed up of it, but please stick to it. It will just mean that we can keep as many people in work and safe and well as possible. So that's COVID. My other question that I've had is around email accounts changing. So some of you may have received an email saying that you need to change your Addenbrooke's email to, or your nhs.net email into your Addenbrooke's one, with a move and possibly adding in Microsoft Teams. The emails that come through from IT look a little odd. I think some people have asked whether they are sort of fake emails and not to, take any notice of them. They are legitimate. I mean, obviously, if you're worried at all, don't click on any links and report it to IT. But if it looks like it's coming and it's talking about you changing your email, it is legitimate. This is what the Trust is trying to do. We will eventually lose our addenbrooks.nhs.uk email, and we will move over to nhs.net email, and that should happen before the end of the year. Please just read the guidance that you've been sent very carefully. Kevin has written some frequently asked questions and some guides, so we'll get that published for you all. I haven't made the plunge yet, but I know some of you have, and it's not overly straightforward, so please make sure you read it and understand it, and you've got some time to work through it when you make the plunge. And my last one on here is around the EPIC Secure chat. So you will have seen, and hopefully some of you attended the briefing this morning, that the Trust is going to stop using non-emergency bleeps, so the bleeps that don't talk to you basically, by the 4th of May. So any of you who have a bleep need to think about what you're going to do instead as a method of communication, and EPIC Secure Chat is the new option. If you haven't tried it, please go and give it a go. It's fantastic. It's a bit like using WhatsApp or any sort of online chat forum. I will remind you all, it is still a work forum, so please make sure your messages are professional, but that's what you should be using now instead of WhatsApping, texting people. It just keeps it all professional. It's all in EPIC. You can link patients into it as well if you're obviously having communication about patients, but please give it a go. And for those of you that still have bleeped, we will be coming around to look at alternative options for you. You can download the EPIC Secure Chats called Haiku onto your mobile phone as well, so you can get it when you're out and about. And so we'll be coming around to talk about alternative options for those who still have bleeps. That was my list of questions. I'm very conscious of time. Has anyone else got any questions? Is there anything in the chat? Oh, Nick is saying thank you. If nobody's got anything else, please send any questions, queries you've got to the Cancer Directorate Senior Team inbox as normal. And the only thing for me really to say on behalf of us all is a massive thank you to all of you for your hard work. I try and say it as often as I possibly can and hope it means something, but it's genuinely appreciated, everything you do. And please make sure you get a break over the coming few weeks with all the bank holidays in, and hopefully the lovely sunny weather will reappear, which is fantastic. So thank you all very, very much. Have a lovely week, and I will see you all soon.